Hi, this is Craig Hoffmeister from Ohio State University, and we're talking about why to participate in clinical trials related to multiple myeloma. These slides were sponsored in part by Multiple Myeloma Opportunities for Research and Education, for which Nancy Kaufman is president. In general, we're told that about 2% of cancer patients participate on a clinical trial. That means only 2% of patients have their experience recorded, are exposed to new treatments, and have an opportunity for something different. In a disease where there is literally 100% risk of recurrence, trying something new should be very appealing. Think about if you were trying to get something done and you were working at 2% of your capability. Now just imagine what you could accomplish if instead you were working at 98% of the pace of development that you would want to achieve. There are a lot of myths and facts about clinical trials. One myth is that clinical trials are riskier than FDA-approved drugs. In general, clinical trials have eligibility criteria for which, if you fit within that eligibility criteria, that clinical trial essentially mandates that it be no riskier than currently available standard treatments. There are clinical trials for newly diagnosed patients, for patients getting transplant, for patients at their first relapse. And at each one of those spots, no doctor can guarantee 100% response for the next treatment, and hence trying something different makes sense. A lot of patients will say, I don't want to be a guinea pig. I want the gold standard. Well, let me tell you, in myeloma, the gold standard has a 100% risk of relapse, essentially guaranteed failure. So the use of new drugs, or potentially the use of old drugs in new ways, may improve results and push us closer to a cure. A third myth is that clinical trials should only be for patients with no other options. In fact, there are clinical trials for just about everything in myeloma. Patients who are newly diagnosed, patients who are receiving maintenance therapy, patients at the time of relapse, quality of life studies to understand how patients feel during diagnosis, transplant, relapse. There are all sorts of trials. Participation on a clinical trial should be available for all patients. If my doctor doesn't mention clinical trials, it must not be right for me. In fact, probably the biggest reason there are a small percentage of patients that participate on clinical trials is related primarily to the fact that patients are not offered participation on clinical trials because their doctor doesn't have a clinical trial available. Multiple myeloma is not a common cancer, and few myeloma clinical trials are available at every oncologist's office, and hence it's best to consult with a doctor that treats only myeloma, as they will likely have a number of clinical trials available for patients at every stage of their disease. All oncologists know how to treat myeloma. Well, actually, the best way to think of this is that oncologists can treat myeloma. And every oncologist knows something about myeloma. But for instance, in the state of Ohio, with about 40,000 new diagnoses of lung cancer, prostate cancer, colon cancer, there are only about 680 new diagnoses of myeloma each year. So what do you think most oncologists are comfortable with? They're comfortable with what they see normally, which is lung cancer, prostate cancer, and colon cancer. Myeloma is a rare cancer, and hence getting a second opinion or getting treated and seen by an oncologist that treats myeloma specifically is reasonable. The trial is more important than the patient. Actually, this never should be the case. And patients are always concerned that even if they feel terribly bad and have a terrible complication, that we'll continue to treat them. And that's absolutely not true. Any patient can stop participation on a clinical trial at any time for any reason. And what is often described by the NIH as a handshake rule, in that clinical investigators shake the hands of their patients and in essence are trying to treat their patients as they would their family. And we would never continue to treat a patient who is having significant side effects. And hence, all clinical trials are essentially patient-centered. And with significant toxicity, clinical trial treatment is always stopped until the patient recovers. Any clinical trial is a good trial. Actually, that's not true. And in fact, one of the things we try to do is partner with our patients to try to find clinical trials that are interesting to the patient. Oftentimes, patients will complain that a clinical trial testing A plus B versus B plus A is not interesting, and I completely agree. We should be doing new and innovative trials that push us inch by inch towards stamping out myeloma. In addition, some clinical trials have logistical concerns that make it unattractive to participate, such as many trips to the cancer center, excessive blood tests or bone marrow biopsies, and while these additional trips may be scientifically warranted, the patient may not have flexibility to participate, and hence not every clinical trial is appropriate for every patient. I don't want to get the placebo actually is a common complaint from patients, and in fact almost no myeloma trials have a placebo arm because most myeloma patients who have anemia, kidney failure, and fractures, almost all myeloma patients need treatment.